Good evening, everyone, or good afternoon, or good morning, depending on where in the world you're tuning in from. And welcome to our third session of today's conference events. I'm Robert Newman. I'm the president and director of the National Humanities Center, and I'll be moderating this evening's panel, which is entitled Medical Research and Global Health Equity, a conversation with industry leaders. On behalf of the National Humanities Center, I want to acknowledge our presenting sponsor, Biogen. Their support, along with that of our other sponsors, RTI International, the Burroughs Wellcome Fund, the Consortium of Humanities Centers and Institutes, Duke Health, Duke University, and the Federation of State Humanities Councils, they've all made it possible for us to make this conference available free of charge to well over 800 participants and registrants who are joining us from all across the United States and from 26 other countries from 5 different continents. This evening, we will be discussing medical research and health equity in a global context, and I'm delighted to be joined by 3 distinguished experts. Chirfi Guindo from Biogen, Hala AlMossawi from RTI International, and Muglia from the Burroughs Wellcome Fund. There are more extensive biographies of our panelists accessible on the conference website, so in the interest of time, I'm going to just briefly introduce all of them. Born in Mali and having obtained degrees in both engineering and business, Chirfi Guindo is now Executive Vice President and Head of Global Product Strategy and Commercialization at Biogen. Chirfi joined Biogen from Merck & Company, where he was president and managing director, working in leadership positions in Canada, the US, France, Africa, and the Netherlands. He brings 27 years of experience in the global pharmaceutical industry, during which he has worked across a range of functions and led innovative access programs for underserved communities. Originally trained in dental surgery and oral medicine in Iraq, Hala AlMossawi is now Vice President of Global Health within the International Development Group at RTI International, a nonprofit research institute that provides research, development, and technical services to government and commercial clients around the world. There she leads RTI's work to strengthen health systems and combat infections and non-communicable diseases in low and middle income countries. In her 24-year career, Hala has served with USAID and other entities as a technical expert and public health strategist, overseeing projects in more than 20 countries in Africa, Asia, and the Middle East. And Louis Muglia is currently the president and CEO of the Burroughs Wellcome Fund, an independent nonprofit research foundation accelerating discovery in the biomedical sciences. Previously, he served as vice chair for research, director of the Division of Human Genetics, co-director of the Perinatal Institute, and professor of pediatrics at Cincinnati Children's Hospital Medical Center. Dr. Muglia's research has over 280 publications, and they focused on genetics, neuroendocrinology, metabolism, and diabetes. He's a fellow of the American Association for the Advancement of Science and a member of the National Academy of Medicine, as well as the Finnish Academy of Science and Letters. And he previously served as chair of the Board of Scientific Counselors for the Eunice Kennedy Shriver National Institute of Child Health and Human Development of the National Institute of Health. So welcome to all of you, our distinguished panelists. It's wonderful to have you with us. And I welcome our audience as well. There is a chat that is available. So please put your questions to our panelists in the chat, and I will be going into the chat occasionally and very much toward the end of our conversation. But what I'm going to do in terms of the format is I'm going to address specific questions to each of the panelists, and then we're going to go into more free-flowing questions and emerge into what I hope is going to be a much more organic and very, very vibrant conversation. So a question first for Chirfi. In your introduction to the UNCF Virtual Life Science Summit in 2020, you described your team's goal as making sure that the medicines that are discovered and developed by our labs are accessible to patients around the world. Could you describe some of the strengths that you found to be most successful at achieving this mission, and where have you come up short?
Thank you, Robert. And again, it's an honor to join this panel discussion and share with such distinguished scholars and humanitarians as Hala and Louis. So, for those who don't know, Biogen was founded about 40 years ago, just over 40 years ago, in the backyard of MIT by, among others, Nobel laureates. And what they wanted to do was to really leverage science for the betterment of humanity. And that really is our motto, our drive, our purpose. The reason why 10,000 employees or so come to work every day at Biogen. It really is to focus on the patient, focus on science, and make sure that the science really gets to patients who need the outcome of that science. Over the years, we have specialized in neurology, neuroscience. Biogen has really transformed the treatment of MS. Today, you can live with your MS a fairly normal life. You could even do athletics, and we have examples of people who are back enjoying a very active and productive life because of the innovations that have come out of the labs of Biogen and others in the industry. So since MS, Biogen has also introduced life-changing medicines in SMA, spinal muscular atrophy. This is a terrible genetic disease that affects about one child out of 10,000. And in its more severe form, these children will die by their second birthday. And so we have a medicine today that can actually allow these children to grow up and become productive citizens. If you're able to diagnose them early and treat them as newborn, you can hope to expand and extend their quality of life and their life expectancy. So how do we make sure that these examples of medicines that I've described reach patients who need them? We're guided by a set of principles. In fact, on our website, we have outlined some of those principles. We believe that we hold ourselves and our employees hold us accountable for living those principles on a daily basis. So I'll just give you an example. How do we price breakthrough medicines? We believe that tiered pricing really is a way to enable access to these innovations. So there's one price for developed countries, a lower price for middle-income countries, and a significantly lower price for low-income countries. This is just an example of the principles that we hold ourselves to. And we try to innovate in the way we bring these medicines to patients by thinking around population health. So we pursue ways in which we can sit down with health ministers. An example I would call out is Turkey, where we were able to sit down with the government of that country to look at the total epidemiology of SMA, the spinal muscular atrophy that I just talked about, and say, how do you make sure that every child who is born in Turkey with SMA has optimal treatment so they can grow up to be productive citizens of society? And let's work together over a number of years to make sure that you can treat your citizens in a way that is affordable and sustainable for your budgets. So we're doing that in Turkey. It's just one example of how we live our principles of access. I could go on and on. You could hear the passion here, but I'm sure we'll come back to that. And perhaps I might also tap into other examples that I was part of during my time at Merck, where we did quite a bit of work in HIV and hepatitis C, vaccines, and other areas of public health.
Great, thank you so much, Chirfi. Hala AlMossawi, you've worked to implement specific global health programming and intervention strategies on the ground in 22 countries as part of your work, and perhaps most notably through your leadership on the USAID primary care healthcare project in Iraq. So how have those experiences shaped the way you think about the relationship between research, planning, and implementation and attempts to address global health issues?
Thank you, Dr. Newman, and it's really an honor to join this discussion. So in general, research, monitoring, evaluation, and learning are key components in the design and implementation of all our programs, including the primary healthcare program project that I managed in Iraq. And research is an important area to take an interdisciplinary approach to global health problems, which are multi-faceted in nature. So what we learned from this experience, that evidence-based, context-specific, locally driven and locally led solutions are very important to lead the agenda at the local level. Also, it's very important to emphasize systems thinking and system practice in health program design, implementation, and learning and adaptation. It's very critical to engage communities, people, civil societies, private sector, as well as governments in the design from early on, in the design, implementation, as well as monitoring of our activities. And also, it's very important to focus on outcomes. We need to make sure how relationships among building blocks, health system building blocks, can advance equity, quality, as well as resource mobilization and optimization, and achieve health outcomes in measurable ways. So, thank you.
Yes, no, thank you. Thank you so much, Hala, and we'll return to some of these issues momentarily. Muglia, your work's focused on maternal and infant mortality, which is a huge global health issue that cuts across regions and nations. And I wonder if you could talk about the importance of balancing the local and specific approaches to these kinds of problems with broader research-based innovation and collaboration.
Thank you for that question, Robert. And first, let me express my thanks again for being part of this distinguished panel. Such a joy to be on with Hala and Chirfi and you. And for those that don't know it, the Burroughs Wellcome Fund is a neighbor of the National Humanities Center right next door in Research Triangle Park. And for those of you that are not familiar with Burroughs Wellcome Fund, one of the areas that attracted me there as president and CEO was my longstanding relationship for them funding undervalued, under-resourced areas in health. And maternal and child health is characteristically one of those areas. Our mission statement at the Burroughs Wellcome Fund is that we serve to strengthen society by nurturing a diverse group of leaders in the biomedical sciences to improve human health through education, empowering discovery and frontiers of the greatest need. And I would argue advances in maternal and child health will have a long-lasting impact throughout human history. Right now, adverse pregnancy outcomes such as preterm birth are the leading cause of children and infants because we've not made progress in those areas despite years of investigation, and we need catalytic discovery. There are region-specific issues around it, such as nutrition, infection exposures, things that you really need to think about locally in terms of low birth weight. But there are also very broad global components of it that we don't understand. We don't understand what causes the timing of birth for any species. So we have to combine these discovery efforts with local implementation efforts to really improve outcomes. And I think that's been one of the greatest joys for me, is to be able to think about how we combine these efforts. We've recently looked at micronutrients in different parts of the world that have regional specific effects, but also genetic differences that have global specific effects. And the Burroughs Wellcome Fund has been invested in the reproductive sciences for many, many years. And we view that as one of the greatest opportunities for health outcomes, because we know it's not only about how you're born, but we know it programs your well-being throughout your life. If you're born small because you're born early or low birth weight, you have a much higher risk for cardiovascular disease, type 2 diabetes, obesity later in life. So we think a little progress in this area would have really dramatic ramifications, and look forward to thinking with Chirfi, Hala, how you think about therapeutics, how you think about delivery in settings where we don't do it very well right now.
Thank you very much, Lou. What I'd like to do now is complicate things a little bit more and go back to each of you with a question, but ask the others to chime in as well. So Hala, I'm going to go back to you first. and ask you to sort of elaborate on your first question, your first answer a little bit. We know RTI's international development focus areas are very committed to strengthening health systems globally. I wonder if you and also Chirfi and Lou can talk a bit about how this kind of work leverages interdisciplinary forms of research and expertise, and also helps to join the public and the private sectors.
Sure, I can start. Thank you. So RTI International was founded in 1958, and RTI is an independent, not-profit research institution dedicated to improve the human condition. So health system strengthening has been at the heart of our mission for over 60 years now. And what we do, it's kind of a dynamic blend of innovation, research, and project implementation to enable us to foster supportive policies as well as systems that improve access to and demand for quality health services. And we apply health system strengthening across our work in infectious disease, in non-communicable disease, and addressing neglected tropical diseases, as well as in advancing the response to reproductive support, reproductive, maternal, newborn child health services, working hand in hand with the governments in low and middle income countries to ensure they have the policies, they have the tools, systems, as well as the capacity, including health workforce in place to deliver accessible, cost-effective, and equitable health services to their citizens.
Lou or Chirfi, would you like to chime in?
I'm happy to start. I'm happy to start. Yeah. No, so I think you mentioned public-private partnerships, and it is so critical that we do this together. No single entity can actually really have the kind of impact that we all wish to have in this context. I'll just give you two brief examples. If you go back to the early days of antiretrovirals and their deployment to combat HIV and AIDS in developing countries, I was working for Merck at the time. I was on the ground in Africa as head of the Africa region for Merck. Initially, there was a lot of pressure to make these antiretrovirals available, and we did under pressure. I have to concede initially. But the problem was there was no infrastructure to use those medicines. And so it took a group of folks, I was one of them, I was fortunate to have been part of that history, to actually select and go and visit with governments in those countries. I really insist it's important to work with governments. You can't just go there as a private party or as an NGO and hope to have impact. You've got to do it within the existing health systems, and you have to help develop those health systems. So we were fortunate in actually finding a country, Botswana it was, that actually saw an opportunity to do a comprehensive HIV and AIDS treatment program. And it was comprehensive because he had prevention, he had education, he had all of the components that make such a program successful. And the company, Merck, and partnered with them, partnered with others, to train and really build capacity in that country. The rest is history, because that program called HAP actually was the proof of concept, which led to PEPFAR, that everybody in this audience, I'm sure, is well aware of. PEPFAR has truly transformed the reality of the life of patients and their families, particularly in low-income countries. So this is one example. We are doing similar things. We're starting to do similar things in the field of Alzheimer's and the understanding of frontline workers here in the United States, working with Harvard, with the Harvard School of Public Health, to try to understand the crisis of frontline workers in areas where you have basically environmental disaster. And so this is a new project that we've started. It's very, very exciting. We're trying to understand exactly the burden that these healthcare workers are undergoing and how we might be able to help them understand the impact of those disasters on mental health and brain health more generally. So more to come on that.
Thank you.
Yeah, if I may add, Robert and Hala and Chirfi, this is a question that I'm really passionate about. I believe that, the really challenging questions we face right now in human health will not be solved unless we bring teams together to address them. It's because they're complicated. They would have been solved already if it were not the case. And they're a combination of biologic mechanisms we sometimes understand and most often don't, social determinants which shape outcomes that we're just beginning to appreciate more and more, including the consequences of structural racism, and then figuring out how we develop a pipeline for therapeutics to bring that into practice. So that takes a diverse skill set, and it's not without bringing people with expertise in each of those areas together that we will really begin to move the needle. So, I think there's nothing more important we can do right now. Bringing together teams does something else, which I'm very passionate about. And it reminds me of a quote by the Nobel laureate Albert St. Georgi. Discovery consists of seeing what everyone else has seen, but thinking what no one else has thought. And these questions that we're looking at, we know they've been problems for a long time, but it's only when you bring these diverse sort of backgrounds together to address it together that you really begin to challenge people to think differently and solve problems. And I think that that's really where we're going to make progress. And by interdisciplinary, I don't even mean just the sciences. I am passionate about integration of science and the arts because I think it inspires us to think more creatively, come out of our shells, and engage the public in a way of being partners with us than we could have done without doing that. And so I think science communication, science and the arts are incredibly important to bring together. And again, I love quotes and aphorisms, and one by Steve Jobs that really resonates with me is that technology alone is not enough. It's technology married with liberal arts, married with humanities, that yields the results that make our hearts sing. And what makes our hearts sing is improving human well-being. And that is something that I think we all want to do.
Well, that's music to my ears, of course, Lou. So thank you very much for those remarks. Let me pick up on what you've just said a little bit in terms of talking about grand challenges, and this is for all of you. We've seen pushbacks publicly against science in the past couple of years, particularly during the pandemic. And I'm wondering, first of all, for each of you, what kind of priorities have emerged in the wider scientific community in the past couple of years, and how has a kind of broad interdisciplinary approach helped address those areas of needs and those priorities? And also, is it important to use that broad interdisciplinary approach to most effectively push back against those who are pushing against science?
It's a great question, and one we've been thinking a lot about at the Burroughs Wellcome Fund and for me personally. And, to me, again, it's about engaging marginalized communities in a way we haven't done before, in a way of engaging populations, engaging people with understanding science, understanding real information, not disinformation, and communicating that clearly and effectively, but understanding where people are coming from to start with. You can push out all the information you want, but you need to understand where people are starting from in their thought processes to really begin to help inform us about how we need to better inform them. And, again, I think looking outside of academia is so incredibly important right now. And people want to see results. They don't want to see another paper published by us. They don't want to see another grant that we get. They want to see something that changes their well-being. And that's what we're excited about doing.
Hala, Chirfi?
Yeah, I couldn't agree more with you. I think it starts with listening, being humble, and being clear about what we don't know, right? So there's been over time perhaps a little bit of arrogance from all of us who represent science, broadly speaking. And every now and then you catch colleagues laughing at somebody because they don't understand the concept, or they don't trust what scientists are telling them. I think there's a better way. The better way is to make sure that you indeed, as Lou said, you try to understand where those folks are coming from. Representation is important in that context. So people who are actually in charge of administering healthcare or delivering healthcare or explaining what science brings to patients and people, it helps when those people themselves are diverse. We need to have people who come from those communities themselves be part of the storytelling, be part of the translation of science into what it means for these patients. So in the case of COVID, we saw that very, very clearly. So if you really want people to believe what we're telling them, if you want people to adopt vaccines or to adopt other measures, it helps to have people from those same communities that we're dealing with. And that's how you build trust, frankly, because let's also be honest, there's been a lot of misuse or abuse of science in many communities. Think about for the folks who are watching from the US, you will obviously know exactly what I'm talking about. Tuskegee and many other examples where trust was broken with certain communities. And so it takes a long time to build that trust again. And so it's important. This is where the humanistic and the liberal arts coming together with science could be very, very powerful.
Yes, I can add also from my end and from experience working with the national programs, it's also very important to engage governments and national programs in the solutions that we offer. It's also very important that the evidence we generate with them, or evidence generated from the research translated into action and translated into policies and the plans, and also there is a capacity at the local level, at the national level to implement these programs. And by capacity, it's mainly we've seen a lot of gaps in terms of data utilization, data analysis, quality of data. So it's very important that we work with them to make sure that they have the capacity not only to generate the evidence, but also to use the evidence to inform decisions, to use the evidence to inform resource optimization, resource mobilization, and also to engage actors and sectors. So it's not only like public health or global health problem is a problem for Ministry of Health or health sector. We need to make sure that we engage others as well from other sectors and actors and apply the shared interest, shared responsibility, and shared risk.
Thank you, Hala. So, Chirfi, let me kind of follow up in terms of public perception. And I ask this question of you respectfully, but of course, that the biopharmaceutical industry has at times been criticized on ethical and economic grounds. So we have a very complicated public image. And some may ask, can we trust the biopharmaceutical industry to be truly engaged in a commitment to public health?
Yeah. No, thank you for the question. I face this question a lot when I interact with public health professionals, because very, very often what you see is there is a lack of understanding, really fundamentally, of the business model that biopharma follows. And so we need to do a better job ourselves as professionals, telling our story, giving examples. And it breaks my heart to we do these surveys every now and then. You read about our image being worse in some cases than the image of tobacco manufacturers. Just try to imagine. We are in the business of saving lives, improving the quality of lives of people, and we're seen as less attractive, less valued, so to speak, than companies that literally make products that do the opposite. So I think it comes from lack of understanding. I'll just point to a few examples. I mentioned HIV and AIDS earlier. I was part of that program at Merck for a number of years. And today, if you have HIV today, you can live a normal life. You can have a normal life expectancy, in fact, because of the medicines that have been discovered and distributed by biopharma, obviously in partnership with many other partners. So if you live with cancer, if you're diagnosed early, there's immunotherapies available. Again, you could live almost cancer-free, so to speak, for a number of years. COVID vaccines were almost back to normal because of the work that Moderna and Pfizer and others have done, again, in collaboration with public sector, with patient groups and so forth. I think, the more we tell our stories, the more we remind people of the value that we bring to society, the more it will help. But it's a challenge, and it's something that we're well aware of. We believe that more information will help. Certainly, the misinformation that exists, that coexists, is a challenge that we're trying to manage. The vaccine hesitancy, the vaccine stories, or the anti-vaccine stories rather, do not help our image. But I can tell you, a company like Biogen, for instance, really truly tries to walk the talk, and hopefully we'll talk a bit more about some of the stuff we do in terms of our environment, sustainability, and governance, our ESG commitments, and how we try to live our values, we try to live our principles, and we hope that people will take notice and will reward us in terms of image.
Thank you. So this is a question for all of you, and we take this in any direction you wish. The title of our conference is A Crisis in Caring. And I'd like each of you to kind of reflect a bit about what has the pandemic taught us about care and about caring.
Well, maybe I can start. It's a wonderful question, and we've all sort of been separated from our usual communities of communication, and I think what it's reinforced to me is how important those communities are for our well-being. But even more importantly than that we don't have to work the way we did. So it's not all gray. There are some things that the COVID experience has taught us about looking after ourselves, looking after each other, that are extremely important, that we can work more effectively, more efficiently, smarter, and do all of the same things that we're doing in a way that promotes wellness. And I think those are incredible opportunities for us to, again, reflect around how we want to move forward, not saying we want to reinvent the past as it was, but how can we do things more effectively? And especially as we heard, the COVID experience with vaccine development is probably the greatest success of modern medicine and biotechnology. It's just an extraordinary achievement to get from nothing to a clinical intervention that has saved countless lives in 18 months. Polio vaccine was 17 years. So to think about how we have come together as a society to move these things forward, government, pharma, discovery partnerships, I just think it's been an extraordinary experience. We're not out of it. There'll be things that come up again, but I think we've all learned a great deal in the process.
Well said, Lou. I think, again, this is a cause to, obviously, COVID has been a challenge and unprecedented pandemic, and so many lives lost, and some could have been prevented, frankly. So that's the bad news. But the good news is the progress that Lou talked about, the speed of vaccine development, just a few months to get a vaccine, an effective vaccine, compared to more than 15 years in the case of polio years ago. But I also think, COVID has brought innovation that has benefited patients in some ways. For example, telehealth. If you think about it, in many parts of developed countries, and certainly in developing countries, there is a shortage of healthcare professionals, not even nurses in many settings, let alone doctors or specialists. Now with telehealth, you could be a farmer in some village in Kenya, and you could have access to a professional in Nairobi who could diagnose you and provide medicine. And in fact, in Africa, you could even send medicines or vaccines via drone. Who would have thought about this? This has been accelerated because of COVID in many cases. So I see a lot of positives that have come out of COVID. If you think about the regulatory side, we've seen acceleration of reviews, much more collaboration between regulators, industry, professionals to get products and vaccines through the system faster, to get clinical trials done much faster. So those are all things that were accelerated during the COVID period. So I'm hoping, obviously, that we maintain those good things that have come out of the COVID experience for the benefit of patients.
And yes, I think what we are facing is really a multidimensional crisis that demands coherent responses. You know, the COVID crisis has highlighted the vulnerability of several systems, especially basic systems, including healthcare, social protection, education, value chain, as well as other financial markets and other systems. And definitely, in addition to the points mentioned, the COVID response also highlighted the need for really building political commitment, and also making sure that we adopt a strategic long-term vision, and also work on integration, like service integration, collaboration, coordination, ensuring kind of whole of government coordination, as well as collaboration with other sectors, and also to engage stakeholders effectively and actively and proactively, and also make sure that we focus on monitoring, reporting, evaluation systems, and also make sure that we think future, right? And we predict for future and make sure that we have the resources and systems in place to help countries respond proactively to crisis in the future.
So if we can stay with the pandemic a little bit, obviously we can't escape it at this point. And I'd like to ask you, how can industry, how can your particular companies in particular, help with the psychological pandemic that follows or is accompanying this physical pandemic? And Rita Sharon last night spoke about a kind of existential uprooting that we've seen around fear and blame, and Chirfi, I believe, has already talked a bit about issues of trust and trauma, and we have a sense of moral injury that has also come with this pandemic. So you coming from the realm of science, how do you help us with this kind of psychological uprooting, this moral injury that is becoming so pervasive as a result of the pandemic? It's a humanities question for all of you.
That's why it's so difficult. Well, I could, what we're trying to do at Biogen, certainly, and colleagues in industry are doing similar things, but we're trying to, really understand the connectivity between mental health and the greater incidence that we're seeing now of depression. And we're trying to see how it might affect other areas of, brain health and overall health. So we're deploying a fair amount of resource to try to understand that. And this is what we, our focus is really science, and we believe science could help to answer those questions. We're collaborating with, as I mentioned earlier, with the Harvard and MIT scientists and others, for that matter, on these topics. But this is the next pandemic. Mental health is going to be the next pandemic. It's really important that we all come together, pool our resources, our knowledge, to try to answer those questions. But we are investing heavily in this, Robert.
One thing I'll take it a little bit different direction, and I hope this is okay. But it's, again, a little bit about what the public understanding of the scientific process is. It's a journey. We're constantly discovering, and there are a few certainties. Things we thought were ironclad today, we find reasons to doubt tomorrow, but it's a growth experience, it's a learning experience. And, I think, especially during COVID, there has been a lot of uncertainty, which again, has brought out sort of mental health challenges, uncertainty, stresses to family function that are just really challenges. And people want answers, certainty, and ironclad sort of opportunities to make progress. But I think knowing that everyone is working as hard as they can to improve health, and it's a discovery process moving forward, with pharma, with implementation globally that we're all working toward. And we don't have all the answers, but we are doing our very best. And I think being able to communicate that effectively without overstating where we think we can go, I think is incredibly important.
I think I can talk about experience from program implementation, like working with health providers, working with like people with TB or people with HIV or mothers, children, with others. So I think it's very important that we apply human-centered design as well, where we understand the drivers, we understand all the factors around the people, like, you know, people-centered design, people-centered approaches, we apply the evidence, and as mentioned, like, we really need to understand the journey, and we need to understand the factors impact. For example, we have seen with regard to TB services, for example, people with TB, they don't go to the clinic, and it's impacted also adherence to treatment, right? So it's a lot of pressure. So what can we do to make sure that they receive the care that they need and when they need it? So it's very important to look at all these factors around people at the household level, at the community level, at the system level. So overall, and make sure that we address all these factors to help them with this psychological impact as well.
Yes, I think you're all talking about better access, and I think that's extremely important. I was reading last night a piece by Andrew Solomon in the current New Yorker about the exponential rise in childhood and teenage suicide rates without any clear evidence or signs, and then there are these sudden suicides, and it's just risen so exponentially. So it's quite frightening, and particularly amongst people of color or LGBTQ teenagers in particular. So let me kind of ask all of you to talk more about equity and access, and how might an increased focus on equity and access, particularly in research, help to mitigate some of the more serious health risks that are facing our global community?
I can start, Dr. Newman. So I think there is a lot need to be done to improve access to health and access to quality of care to achieve health equity. We learned from like previous interventions designed to reduce healthcare disparities that there are many challenges, but recent interventions really showed promise in addressing fundamental knowledge as well as translational gap. So we think that scalable, multi-level interventions guided by research collaboration, broad stakeholder engagement will be very, very important, as well as critical to more sustainable community and system level changes.
I'm happy to chime in as well on this very important question. So you mentioned you wanted us to focus more on the research side. I could also comment on the access side, maybe.
Yes, please.
Later. But on the research side, traditionally for biopharma companies, it's been very challenging to enroll diverse populations in clinical research for a number of reasons. One of which being trust. I talked about trust earlier. Another reason is that traditionally it's been easier, faster to enroll in what I would call your traditional academic medical centers, where your staff has their connections, they know how to do research, they've always done research, they can produce the goods more rapidly. I think more recently, certainly Biogen has been one of the companies trying really hard to tackle this problem. And it's harder because when you go to minority communities in particular, when you go to rural communities in the United States or Canada, for example, you tend to have people who have a higher incidence of comorbidities, right? So your inclusion-exclusion criteria would tend to exclude many of those patients. That's number one. Number two, access to simple physical access to your sites of research is a problem. Trust is a problem in some of those communities. And so how do you address this? We have started to work at grassroots level with people who actually know how to do this, people who come from those communities. One example I would call out is the National Minority Quality Forum in the United States. This is an organization that has been at this for over 20 years. They have developed a really excellent database where they can tap into the census data, they can tap into the clinicaltrials.gov databases, they can tap into the Medicare, Medicaid databases, so they can tell you per zip code in the United States, where are people who have a higher prevalence of, say, Alzheimer's or Parkinson's and so forth. And where are those, within those zip codes, what is the percentage of African American, Latino, Native American, and where are the current clinical trials deployed? So you can see a heat map very clearly of where the opportunities are to go for intervention. And so once you do that, then you go into those communities together with the local leaders and you have conversations, you hopefully begin to develop trust. And then you can have people, enroll in trials. You train the local staff. So we've been doing it. We were successful at deploying a particular study that was presented last October at the ECTRIMS conference. This is an MS conference where we enrolled 40% of the subjects as African American. This was never done before in our field of multiple sclerosis. It took that much effort and really collaboration with communities, with organizations that know how to do this, the National Minority Quality Forum, as I mentioned earlier, to be able to execute this. And we're trying the same approach now for lupus, we're trying it for Alzheimer's and other disease areas, but it's really hard work. And we believe that there's there's an opportunity also for industry overall to tackle this problem. And I know the bio and pharma associations are working on this. But it's very, very hard work. So I might comment further on access later. Thank you.
No, a really important question. The data is surprising to me, Robert, amongst these communities that now, I think during COVID, especially, we've tried to enhance our desire to embrace diversity of all types, include marginalized populations, whether it's race, ethnicity, sexual identity, geography. And so to see increased, suicide and death amongst, especially adolescents, it just says how stressful and uncertain a time this is right now for many people. And it surprises me. Another statistic that surprises me is that automotive deaths are the highest they've been in the last several decades as well. And what is this confluence of psychic disconnect that brings all of these adverse outcomes together? And I think we have a lot to learn. But, again, I think that doesn't deter us from really wanting to engage populations that we haven't really been able to impact before. And it's not about doing it to them. It's partnering with them. It's embracing them. It's collaborating with them. It's understanding what they want to accomplish in their communities that make it work. And the title of the session today was Medical Research and Global Health Equity. And as we think about what that really means, what is global health equity? It means being able to deliver the same kinds of advances to every person, no matter where on the planet they're from, no matter what background they're from, no matter what faith belief they have. And there are limitations because we have not gauged those populations well. So we don't have data in terms of what they need necessarily. We need to make a major push there. They don't necessarily have the experience and capacity in terms of the technical resources to be able to implement new findings if they're there. And then just delivery. Just delivery of therapeutics, of resources is challenged in many parts of the world. So how do we address all of that while we're making discovery and not leaving populations behind as we're able to move things forward for everyone? And so I think really data collection in these populations is incredibly important, but that's going to take trust. It's going to take trust. It's going to take the humanities. It's going to take conversations.
Thank you all. So I want to invite the audience to put any questions that they have into the chat, and I'll start dipping into the chat momentarily. But let's continue on this concept of equity and access and talk about technology a bit. We know that new technologies can enhance and expand research efforts, but they can also widen the gap between those who have access to technology and those who lack it. So I have two interrelated questions on this topic. First, what are some of the barriers to the efficacy of health-related technologies in a global context? And second, how can we responsibly use technology to create more equity in our research and our approach to global healthcare?
Well, maybe I can start out with this a little bit. You know, again, it takes, again, information access to be able to make progress. Biologic information access, electronic health record information, environmental exposures regionally to be able to do this, integrating it systematically to understand how to make rational interventions. And right now, as Hala mentioned earlier, we have to partner with governments because they're putting up barriers to be able to share information, to share biologic information, to share health information on populations that, again, requires building trust. So building trust globally is just a critical component of all of this. Again, as partnerships, not as any one entity descending to say, you know, we're here to help you, just listen to us, but how can we listen to you? And again, as Chirfi said, being humble in the process, I think, goes a long way.
Yeah, thank you. I can add as well. So we know that kind of the key barriers include infrastructure, equipment, or technology gap. But when we work with countries, we go with agenda and we go with funding and we implement programs and we come up with these technologies, and key gap that is the sustainability of these solutions, in like the resources and the capacity. So the capacity for them to sustain the solutions or the technologies that we kind of introduce, and also the capacity to sustain them financially, but also the human resource capacity, which is kind of the technology gap, for them to take it to the next level, to scale up, to replicate, to add on, like, you know, to address other issues. That's why many solutions kind of continue there as long as there is funding, or as long as there is a kind of implementing partner to do them. So back to the same point that we discussed, it's very important to engage governments, to engage national programs, to make sure that they are part of the design. That's why what I love about the work that we do with USAID now, with the new model of co-creation and co-development, where we look at the challenges and the problems with them early on, identify the solutions, identify the priorities, look at the resources, look at the stakeholders who should be engaged, and also make sure that we look and we start with sustainability in mind. Like, you know, we start with sustainability, we start with them when we implement the programs, that they have the resources from the beginning to continue and to transition these programs to them smoothly, where they can continue the work after we end these projects.
Yeah, what I would add, no, I could not agree more with my colleagues here. I see the positive, Robert, coming out of this. Obviously, we all know the barriers. Hala mentioned it: infrastructure, broadband, electricity supply, you know, you name it. But if you're able to address those to some extent, working with governments, indeed, then I think the opportunity is huge. You know, I go back to the African example I mentioned earlier. You take a country like Kenya or Rwanda, for example. Mobile phone internet access via cell phone is available to 87% of the population as we speak today. 87% of Kenyans have access to the internet via mobile phone. And Kenya has one of the highest penetrations of mobile phone banking today in the world. I mean, who would have thought, right? And so Ghana is the first country where vaccines, COVID vaccines, were delivered via a drone to villages. I mean, this is what technology can afford us today. And this happened more than a year ago. It happened in Ghana before it happened in the United States, for delivering COVID vaccines to patients in remote areas. And so, and companies are being formed by young people. I was just in Mali last December for Christmas break. You know, the vibrancy that you feel, that you see, is absolutely mind-boggling. And so, you know, the southern people in the South are moving, and technology is enabling that. You know, Google, Facebook, Amazon, they're all setting up coding centers throughout Africa. I mean, obviously, they all started in South Asia, as we all know, but they're going throughout Africa, Latin America. So technology is really leveling the playing field to a very large extent. You could be a farmer today in Central America or Central Africa. You have access to pricing information on an ongoing basis. So you no longer have to be taken advantage of by middlemen. So you know exactly what the prices are. You can negotiate better. And so the real barrier, I think, is, you know, government, you know, policy in many cases. It is still infrastructure in many cases, but where there is minimum infrastructure, I think technology is enabling access. It is leveling the playing field. It's providing information to people who need it, and it's doing good for society. I'm really excited about the opportunities. It's just one last thing I'll say about technology, because I think it's so cool. We started a study here in the United States with the intent of expanding it globally later on. This is so Biogen coming together with Apple to try to understand whether we could predict the incidence of early cognitive decline by people who are just going about their daily activities. You're using your cell phone on a daily basis. You're doing your Google searches. You're doing your, you know, what you do normally. And passively, there's an algorithm behind that is actually, you know, collecting a lot of information, and through predictive modeling, the algorithm will be able to tell you, you know, obviously this is all, you know, consented in advance. The algorithm will be able to tell you whether you need to go see a doctor, because there are patterns that the system is able to detect in the way you use your cell phone, the way you use your voice, and so forth. That's the power of technology. And so if you could identify these patients very early through lifestyle changes and other interventions, you could delay the incidence of dementia. I mean, think about the societal benefit of that, the individual benefit, and the economic benefits overall. So that's, again, the power of technology.
Yeah, and similar strategies using language processing on mobile phones have been used to screen for mental health disorders and suicidality. And you know, I think it's just the form thrust of what technology can offer to save lives.
That's right.
So we have a question in the chat from Don, and he asks that you've all spoken about the importance of data in setting public health priorities. And he wonders if you could share some examples of particularly meaningful qualitative data, qualitative information that you've relied on in your organizations.
You know, I think some of the qualitative data we've relied on has largely been around science communication and distrust by populations, not sort of, you know, recognizing many of the benefits that have happened and finding the need to really convey information better. I think we've used a lot of quantitative information to recognize really access disparities that we can use to foster equity. Because in North Carolina, broadband is not everywhere even. It's not even a global problem, it's a local problem. And students have had issues, a lot of what parents are experiencing in terms of their stress. And what we've done is actually engage early career investigators that are really struggling with their balancing of family and COVID-related issues, shutting down their research programs, to intervene to give them resources that they otherwise would not have had to provide ancillary services. We've partnered with Doris Duke, American Heart Association, Rita Allen Foundation, based on this qualitative information that we've gotten from people thinking about leaving productive research careers because they just can't handle it all.
Hala?
Yes, I can share experience using machine learning, for example, and we all understand the importance of social and behavior change. So this is where we send some questions to mothers, like using mobile phones, about their experience coming to the facility for whatever antenatal care or vaccination, and ask for responses or ask for feedback. And this is qualitative data, right? And we gather millions and millions of inputs coming from countries. This is very important as we look at the data to make sure when we design our social and behavior change interventions, like specifically care-seeking behaviors, how we use this information, and it's very, very useful for us as we design our interventions that are very people-centered and context-specific based on the qualitative data that we collected.
Yeah, I mean, very similar experience at Biogen. In our line of business, we interact mostly with health professionals, as well as payers and policymakers and patient advocates. So we do surveys on a regular basis. We ask them questions about, how, rating our quality of service, and how do they want to interact with us? Do they prefer to have a person on the phone? Do they prefer to have a person visiting with them? Do they prefer to just be left alone so they can connect with us digitally when they need to? So we do have those kinds of value surveys, and we do mine that data. And so that data is something we then analyze, to Hala's example, using various techniques to then inform how we set up our teams, how we invest in resources that are ultimately intended to provide value to customers, value to stakeholders that we serve around the world.
So 3 years ago, the National Humanities Center did an international conference entitled Beyond Despair. And we talked about how the humanities might address the issue of climate change. And I think we clearly understand now, of course, that climate change is a threat to global health concerns. And I wonder, the National Academy of Medicine has established the need to address interrelated topics of climate change and human health and equity as one of their grand challenges. So what are some of the actions that your respective industries, your respective fields have taken in response to climate change? Your respective organizations have taken in response to climate change, and how might we do more to promote awareness of climate change as a threat to global health?
I can start, Dr. Newman, with our work with RTI's work with the National Academy of Medicine Action, where we work with them to help galvanize a movement within the health sector to mitigate and adapt to climate change, while centering and maximizing human health and equity. So our senior science and epidemiologist, Pia McDonald, just met with the National Academy of Science organizers for the National Academies of Medicine Climate Grand Challenge just today, where they talked about directions for 4 programs, and the 4 programs and areas of collaboration and work include communicate climate crisis as a health and equity crisis. And the second area is to develop a long-term roadmap for systems transformation. And the 4th area is to prioritize decarbonizing health sector. And the 4th area is kind of bold and interdisciplinary solutions to accelerate actions. And in addition to that, also we are or we can support the NAS in 3 areas to advance their grand challenge, including educate lawmakers about the importance of this effort and the need for more funding, as well as to engage in the work being done at NAS with scientific committee and respond to any of the calls for proposals or applications to do the landscape analysis for scientific review. So this is something that we do and we lead here at RTI with the academy.
We at Burroughs Wellcome Fund are taking on climate change and human health as one of our major priorities. This started just as I was starting as president and CEO in January of 2020, but it's really been our major thrust for the last 2 years. And we have become the foundational sponsor for the National Academy of Medicine's initiative in their grand challenge for climate change and human health, supporting the infrastructure, supporting pilot grants at the National Academies. But then we've also developed our own investment for first pilot grant proposals that we accept on an ongoing rolling basis. And they've been incredible. We've gotten now more than 120 pilot grant proposals, ranging from theater and climate change initiatives to science education to looking at adverse health outcomes from regional exposures. So both global and, again, local sort of issues, wildfires, ocean coast changes, that all will impact this, that we're very passionate about investing in. And to me, this is one of the areas we need to inspire the next generation of scientists to really take on. This is the challenge for the next 100 years.
Similar here at Biogen, climate change for us is one of the 3 key priorities. We see climate change really as an existential crisis for mankind. So absolutely. As a result of that, 2 years ago, our board and our executive leadership committed to investing $250 million over the next 20 years, specifically directed at contributing to the fight against climate change. We're going to do that in 3 different ways. First and foremost, it is about going fossil fuel free by 2040, right? And so we want to be one of the leaders in our industry in going 100% fossil fuel free by 2040 throughout all of our operations. Just to give you a sense, we have 60 manufacturing sites that are either owned by Biogen or operated by partners that operate facilities that make medicines around the world. And so we want all of them to go fossil fuel free by 2040. Last year was the first year in which 100% of all the electricity that we used through our operations came from renewable sources, right? So this is one way in which we're attempting to address climate change. The second is our own employees. So we've been educating our employees, we've been setting goals, and we've actually also set out some incentives to encourage our employees to move green in their households, right? Giving them help and support to adopt green technologies in their household. We've moved much of our fleet in 13 countries to EV. So that's another example that we are following and accelerating. So the third way in which we're addressing climate change is through collaborations and partnerships, leveraging science and trying to understand the connectivity between climate change, particularly air pollution, and brain health. I talked about that earlier, the work we're doing with Harvard, MIT, and others. There's a lot of work that has already been done that creates connectivity between air pollution and stroke, for example. That's very well documented. There's increasing understanding of the connectivity between air pollution and dementia, the incidence of mild cognitive impairment. But we need to do much, much more in this area. So Biogen is committed to doing just that in collaboration with these partners. So these are 3 specific priorities that we have set ourselves, and they're incorporated in our corporate scorecard, right? So if you look at our, how we determine our performance as an organization, one measure of that is our ESG, and then climate change, climate action rather, and our strategies are part of our ESG goals that are incorporated into our scorecard, which ultimately determines bonuses and compensation for everybody at Biogen.
Well, thank you.
Very similar to that for Burroughs Wellcome Fund.
Mm-hmm.
We generate our resources to invest in science by investing our endowment wisely. And we've taken into a very careful assessment of ESG in terms of all of our money managers, in terms of where they're investing our endowment, and hold them accountable for the standards that we hope to maintain. No fossil fuels, very high standards for environmental impact, because we want to live what we preach. We just don't want to say, we're going to invest in this work, we're going to abide by it in terms of how we work as an organization.
Awesome.
So Joe from the audience asks, from a global health perspective, how do we deal with suffering in different registers and in different cultural contexts? So for example, he says, how do we deal with chronic pain, both in its expression and its treatment in these different registers and different cultural contexts? And I would also conflate that with how do we deal in terms of setting priorities with the suffering, more specifically affecting healthcare workers, the mental health crisis that we see throughout healthcare workers in this country in particular.
So, I'm happy to give it a start. Actually, since you mentioned healthcare workers, there was a study I read recently that showed that 18% of nurses in the United States actually have, suffer from significant depression leading to suicidality. So these are really, really high numbers in the United States. The numbers are probably higher in resource poor settings. I don't have reliable numbers. Maybe Hala, you might have some data on that. But I think this whole concept of culturally competent care is something that really is critical and has become even more important in the last couple of years with COVID, as we begin to understand the disparities of care, the disparities in delivery, both in rich countries as well as in developing countries. I go back to the United States, since we're here. If you are Black in the U.S., and this has been documented, right? So for the same health condition, you are less likely to be seen as, or to be, you're assumed to be more tolerant of pain than if you're a Caucasian patient. This has been very well documented. This comes from the legacy, obviously, of this country. And so we need to talk about these things. I think the conversations that have started, particularly accelerated from the George Floyd murder a couple of years ago, have been very helpful. At Biogen, we have these conversations on a regular basis. We try to train our own employees and to be more aware, right? To be more aware, to understand some of the unconscious biases that exist, that we all have. So if we do that, I think we have a chance to overcome some of those challenges, and just make sure you have a diverse talent that can help one another understand those issues. But it's really complex.
Yeah, I think this is a very challenging question, as to how to understand pain and suffering in different cultures. And I think it's being, again, sensitive and aware that it's not all the same. Again, listening and wanting to understand how best to help given the circumstances these cultures are in. And then finally, I think it's not making it all about the technology. Medicine is a humanitarian discipline. And I think ultimately, at the end of the day, we have to bring our spirit of wanting to help people into the discussion, because I think that is what we can give most, is our own partnership with humanity. And it reminds me of a little bit of the Abraham Verghese quote in Cutting for Stone. What treatment can be given in an emergency by ear? It's words of comfort. And I think often we don't provide enough words of comfort to people to help them through these areas. One thing we've done, which I think is pretty fascinating and fun, we've partnered with Peter Sellers at UCLA, who's a professor of theater there, to develop a multimedia presentation on suffering based on the Vimalakirti Sutras from the 1st century AD. And this has been rolled out at various film festivals, and it's meant to be shown in hospices, hospitals, for people with suffering around the world. And it got a little bit delayed by COVID. It was going to be rolling out, but it's a super beautiful piece that he's put together, and we look forward to sharing that with the world.
What a great project. Wonderful project. Hala, do you have any comments on this?
I think maybe just a few things around, like, the kind of the support that we have to provide to healthcare providers, and maybe approaching this more from policies, where we need to make sure that we have these occupational health and safety standards, and also make sure that the system is supportive of healthcare providers when they need the support. Same thing with the people who are receiving care, right? We need to look at models. We need to look at context-specific models, like some examples of really amazing work that we have done through engaging, I think one of the questions, if we have time to address it, engaging faith-based organizations. Mm-hmm. And engaging civil societies, women groups, all like this. There are many ways to approach this problem, because it's really very complicated, but very important.
Yes, I'm glad you responded a bit to that question that was in the chat about how do we use faith-based groups as well. Yeah. And while we're on the subject of policy and political barriers, I want to go to a question from Marina in our audience, who is asking another complex and complicated question. How do you address political barriers to data collection, particularly on LGBTQ populations and on women? Barriers that she says are more about being ideologically opposed to equality and really have little to do with building trust.
This is very complicated. At least at Biogen, I think I can speak also on behalf of the broader biopharma industry. We tend to be, we're data-driven. We do encourage transparency of data, but unfortunately, in some cases, in some countries, you can't collect certain data that is, in fact, very important for research and for understanding of the patient needs and patient, and so we can serve the patient better. At least in the United States, we are able to do that. We are able to collect that kind of information to inform drug development, to inform patient-reported outcomes. It's really important that you actually get patient-level data to fully appreciate the use of your medicines, your interventions in the real world. And so there's been a lot of work in this field, and certainly with the availability of technologies now, we can process that data and turn it into information that is relevant for decision making. But it's not possible everywhere. That is correct.
Yeah, I think it's a very it's a great question, and what we've done is, I think, paid attention to engaging these communities, and one of the best ways we've had of doing that is through many of our awardee networks and advisory committee member networks. We look forward to supporting sort of near-peer mentoring activities, engagement, to better understand what the issues are that we can help with, because, again, without hearing directly, you don't want to assume. And I think, especially acquiring data, it's hard to know how to ask in a way that is not breaking barriers of trust, of confidence in many ways. So we've been actively trying to determine, how best to understand how we're supporting these communities in terms of who we fund and in terms of who we engage on our committees and who we engage on our boards.
Great. So Antoine in our audience asked, I think, a very powerful and penetrating question. She refers to Rita Sharon's suggestion last night that one of the most important things that scientists and medical professionals can do is figure out the right questions to ask. And she asks, how have all of you identified meaningful questions that inspire and direct your work? And what are some of those questions that you could share with us?
Certainly, from a biopharma standpoint, one of the things I could tell you is many of us joined this industry. We joined this industry because we want to have impact. We have a very high concentration of MDs, MD PhDs, nurses, people who come from the health professions. They tend to be the majority of the people working for Biogen and for the industry in general. And so when you ask them questions, you ask them, so why do you leave clinical practice? You know, you were a professor of medicine, you were seeing patients, now you're working in research for Biogen. Why did you do that? And so one example I would call out is this particular scientist telling me, you know, I was in my setting, I was doing patient care. I probably had impact on roughly 200 patients and their family members, right, as a specialist. Now, at Biogen, I could impact literally hundreds of thousands of people, millions of people, right, by discovering, right, the first drug against ALS, by discovering the first drug against Parkinson's disease. You know, these are areas of significant unmet need. These patients are suffering. There's no treatment for them at all. There's no treatment that works. And so, you know, this particular scientist was telling me what keeps me going is to be able to be one of those team members who've, you know, found a solution for disease-modifying treatment. So that, I thought, was one way to approach it, asking the question, why is it that you're doing what you do, right, versus other options?
I can share also from my side as well. I mean, our goal is to use evidence-based science as well as science to improve a human condition. So we ask ourselves always, how? What else? What else we can do? Who else should be engaged? How can we do things differently? So innovation is key to our work, as well as assessment, evaluation, learning, collaborating, adapting. We kind of look at the way we do things and improve and make sure that we are focused on outcomes and focus on improving human condition for people we serve and communities we serve.
Yeah, maybe I can just add a little bit about my own personal experience here. You know, I think this idea about how you decide on a question that inspires and motivates. And again, it has to be a long-term question. And for me, these questions are usually big and simple. They're not hard to understand. When I was a pediatrics resident in Boston, I spent 6 months in a neonatal intensive care unit, taking care of babies that were suffering, dying every day because they were born too early. The toll on the families was incredible. We had no intervention that helped them. And to me, the fundamental issue was we don't know what determines the timing for birth. Most of it was idiopathic. Babies were born early for no reason. And for me, the big question became, what determines the timing for birth? It's as simple as that. And it's a simple question that's a very hard one to answer. And to me, that's driven my career. And fortunately, we've been able to understand biologic mechanisms now through doing human genetics and genomics. We've identified the first dozen genes in the maternal genome that determine birth timing. And we hope those serve as a foundation for Chirfi to develop drugs in the future and Hala to think about how we implement this globally to impact this problem.
Thank you very much for those responses. Hala, you wanted to say some more about engaging faith-based organizations. I'd like to kind of wrap your response into a broader question for all three panelists, and that is, how can we find opportunities for local communities and local people to become more involved in designing and implementing global health solutions? So Hala, I'll start with you, please.
Definitely. Great question. You know, I have a huge passion personally to work with local partners, work with the local communities, engage them. You know, they are the future. We are not there, you know, all the time with them. So they are leading the agenda there. So I can share maybe a few examples of kind of really successful experiences in engaging faith-based organizations as well as local organizations in leading the response in areas where, you know, in communities where really people listen to religious leaders, right? So in Indonesia, for example, you know, Indonesia is one of the top high or high burden TB as well as MDR TB countries. So one of the projects where we engage these faith-based organizations to communicate and to educate and to advocate for TB prevention, to advocate for seeking care at the facility level. And we all understand that vulnerable, hard to reach population, most of the missed cases there at the community level. That's one example. Other example from the Philippines, engaging Muslim religious leaders in educating mothers, educating families about family planning, which is it's one of the sensitive topics there. But through engaging these local organizations and engaging specifically faith-based organizations, we were successful in one of the programs that I managed under one of the projects before in 2019. It was very successful experience engaging these organizations. So I think it's very important to identify these challenges, and also to make sure that we reach out to these local organizations, communicate the challenge with them, and work with them to define the solutions.
Anyone else?
Just a brief comment from my side. I think in our case at Biogen, we try to engage with community health centers. These are communities that serve local folks in their environment. The healthcare workers tend to come from those communities. We have found that to be a very, very powerful way to reach communities, diverse communities, and do research, do education, and begin to build trust. So just one thought.
Yes, and I've been able to participate in many initiatives called collective impact collaboratives that bring together faith-based communities with health systems, with academic institutions, that set a series of shared metrics for determining the health outcomes around the areas they're interested in. And by bringing together all of these groups that share the same measures that they want to impact, you make much more progress. And I think it's been very powerful.
So to wrap up things, I'd like each of you to reflect a bit about something that in your work recently makes you hopeful and makes you think about the responsibilities of the next generation of global health advocates. Can we start with you, Lou?
One of the things at the Burroughs Wellcome Fund that I've been, was an attraction to me to begin with, that has just resonated with me further, was our investment and connection with the K-12 school systems in North Carolina and beyond. And I see such energy and innovation and enthusiasm by teachers that want to inspire students at all levels to appreciate these healthcare problems, to think about how to address them, and then to think about their futures in making meaningful progress. And to me, if we can inspire these individuals through engagement around discussions such as we've had tonight, around partnerships with science and the arts, around connections with museums and national activities that really do embrace innovation, I see enormous potential, and it will be people following their passion. I think there has been more now opportunity to think about diverse careers than there has ever been before. And so I'm very excited about that and hopeful that it will be these, again, transdisciplinary, bridge spanning individuals that really make the future great.
Thank you. Hala.
Sure. Yes, I'm very hopeful and also very optimistic when I see the resources, when I see the capacity, when I see the talent there at the local level, right? That's amazing, and also very amazed by the work that we have done here at RTI, engaging local organizations, research institutions, researchers, universities, national programs, engaging them in defining their solutions, and also working on not only transferring the knowledge from this side or transferring the capacity, but also exchanging this with them. So which is great. I'm very, very optimistic about the future. And also I think for the next generation, it's very important for them to think locally and act locally. It's very important for them to also look at kind of priorities and challenges really 10 years from now. Yes, we need to respond to key like problems that we are facing, but we really need to think a future and think sustainable solutions.
And Chirfi.
Yeah, so, if you think back the last few decades, I think society, working all of us together as professionals, we've actually, to a very large extent, taken care of infectious disease. Now, of course, COVID is a blip. I think it's fair to say that we know how to handle COVID, and we've developed vaccines. We will continue to do so. Cardiovascular diseases, right? So people are living longer now after a myocardial infarction. You don't have to die of cardiovascular diseases in general, the way you did even 20 years ago. Statins have transformed the outcomes of many patients around the world. Cancer, people need not die of many types of cancers nowadays. You could live a quasi-normal life if you detected early and if you treated effectively. I could go down the list. The one exception is neurological diseases, right? Alzheimer's, Parkinson's, ALS, right? So neurodevelopmental diseases. And so as I think about youngsters making a choice or thinking about what to do in the future, I would encourage them to consider getting into neurological sciences research, because this is where we need the best minds to come together to develop the next cures, the next treatments, because there are so many patients who are suffering. This is the second cause of mortality in the world and the first cause of disability in the world, neurological diseases. And we only understand maybe 5% of the brain, less than that perhaps. Lou, you are the expert here. You should keep me honest. But we understand less than 5% of the brain. So there is so much more that we need to understand, we need to learn. And so this is an exciting field. We have new tools in the toolbox now, data analytics, machine learning. We have tools that we never had even 5-10 years ago. So this is the time to get into neuroscience and find solutions that patients are desperate for.
Well, Chirfi, Guindo, Hala, AlMossawi, and Lou Muglia, thank you so much for an incredibly thoughtful and capacious conversation. And thanks to all of our audience members for your participation and for your excellent questions as well. This conversation will be recorded, has been recorded, and will be available and readily accessible for the future on our YouTube channel. And we will reconvene tomorrow, the conference will, at 1 p.m. Eastern Time, for a panel that will continue to explore the challenges of addressing medical needs across national and cultural contexts. And that panel and our sessions on Thursday will continue and expand upon these amazing conversations that we've already had. Again, all of our sessions are available on the National Humanities Center's YouTube channel. Thank you, everyone, and I look forward to seeing you tomorrow. Good evening.